Hello, everyone. I'm Emily Actrizandi, Vice President of AtlanticLIVE. And if you are just joining us, I want to welcome you to Pulse, our annual summit on healthcare. We convene dozens of in-person and digital events a year, and it is safe to say that this is one of the most critical programs amid the COVID-19 pandemic. People across the country are justifiably concerned about their health, asking questions about how to get the right care, and they're questioning the structural inequities in our system. These issues were around before the COVID-19 pandemic, but have been exposed even more in recent months. Over the next 30 minutes, we'll hear how healthcare leaders in two American cities, Atlanta and Washington, D.C., are addressing disparities within their own communities. I want to thank our underwriter for today, Bristol Myers Squibb, for their support of Pulse. And now I invite Shamika Williams, who leads the Black Organization for Leadership and Development at Bristol Myers Squibb, to provide opening remarks. Shamika?
Thank you. Good afternoon, everyone. My name is Shamika Williams, and as you've heard, I am the Global PBRG Leader for BOLD at Bristol Myers Squibb. BOLD's mission is to accelerate the performance of Bristol Myers by fostering an inclusive environment that values the contributions of others, specifically Black colleagues. Like many of you, we have all been impacted by the COVID-19 virus, and hearing the impact our family and friends, then understanding that this pandemic has had a disproportionate impact on the Black and Latino communities. According to the CDC, in the United States, Black and Latinos in America are contracting COVID-19 at a rate of 5 and 4 times that of our non-Hispanic white persons, respectively. Healthcare disparities are not unique to just COVID. It is just one example of the multifaceted issues within the healthcare system. For BMS, we are taking proactive steps to promote public health, address disparities, carry out our mission of providing life-saving medicines to our patients who depend on us. We're developing strategic frameworks and establishing metrics specifically around our clinical trials, leveraging existing activities to reach diverse and heavily burdened populations, and providing cultural and enhancing mechanisms to communicate the importance and the values of these initiatives at the enterprise level. One key priority that we are working on at Bristol Myers Squibb is specifically focusing around diversity and representation in clinical trials. For example, Black patients have a 60% higher incidence of prostate cancer, and yet only represent 4% of the recruited people in the US clinical trials. Through our dedicated outreach within Bristol Myers Squibb, we created a focused recruitment strategy that was able to enroll 18% Black patients, which is shy of our 20% goal, marks important progress and provides a roadmap for the future of Bristol Myers. Globally, we have the BMS Foundation, which is helping us across the enterprise look at health equity and really partnering in with the communities to engage with key stakeholders to develop great models to get us to help close the health disparity gaps. We have had rapid mobilizations when it comes to the COVID crisis at BMS. We have been providing supplemental grants to groups that are serving high-risk populations. With our PBRGs, there are 8 currently at Bristol Myers Squibb. We have multiple initiatives, many of which are focused on helping our community, including our partnership with the BMS Foundation, BOLD and OLA, where we partnered in with the Hip Hop Public Health Organization to create a COVID PSA video specifically focusing on the Black and Latino community, leveraging Dougie Fresh and multiple Black and Latino celebrities to reinforce that message of social distancing, wearing masks, and hand washing. Critically important, we have another group called Dawn that has a Share Smile campaign about sending notes to inspire isolated individuals in this time of isolation that we're living in. And our Veterans Community Network has a partnership between Rubicon, specifically focused in on a COVID-19 food emergency response, which is really specifically to help people in need right now with all of the different outcomes that have resulted as a result of COVID-19. While progress is being made and we are doing a lot more with the respective PBRGs that exist and across VMS, we have a lot more to do. And with that, I would like to now turn this back over to Emily for introductions to the panel.
Thank you, Shamika, and thanks again to Bristol Myers Squibb. And now, before we dive in, a quick reminder that you can be part of the conversation by submitting your questions through the Q&A feature on the bottom of your screen. Keep your questions short and on topic and let us know where you are watching from. And now I'll turn things over to the Atlantic's Vann Newkirk to lead the conversation. He is joined by Dr. Sandra Ford, District Health Director for DeKalb County, Georgia, and Dr. LaQuandra Nesbitt, Director of the District of Columbia Department of Health. Vann?
All right. Well, thank you, Emily, for the introductions, and thank you, Shamika, for setting us on the right track with what we're thinking about today. And thank you, Dr. Ford and Dr. Nesbitt, for joining us on this session. I want to kick things off. I'm always sort of just amazed by the fact that any health professional right now is able to do any type of media or these type of events. I always just envision your days to be right now just full of running about. And so I'm glad you're here with us. I think one thing that makes sense to do right now is just to get a sense of where your cities are in terms of this pandemic and what we are looking at on the ground.
So I'll start because Metro Atlanta is struggling right now. Our numbers are going in the wrong direction. You know, when COVID first started, we talked about this wave that we were anticipating, and a wave is something that goes down and back up. We've never went down. So we're just in a sustained level of you know, increasing numbers of individuals with virus load. A lot of what we're finding, of course, is more asymptomatic folk, more younger folk. And so the demographic that we were initially concerned about, which were our seniors, now we've expanded that to our youth. And so the restrictions in Georgia are much looser than in some of the other states and cities. And so we're seeing a lot more folks out and about. I actually visited DC a few weeks ago and was very impressed by the fact that they seem to be very shut down. And that's not something we're seeing. I also saw more folks wearing masks there, unlike what we see here. And that's because we have so many different municipalities and cities that it's hard to regulate, because you could literally cross the street and not have a mask ordinance where on the other side you may. So it's been a real challenge.
And Dr. Nesbitt, we just introduced DC, so.
Sure. Here in Washington, D.C., we have been able to have some market improvement. And it's hard to say that as a health director, because any day when you are still having cases of COVID-19 and having people who are losing their lives to COVID-19, it is disheartening as a health official. Especially when it's something that where we know there are things that we can do in terms of wearing masks, in terms of social distancing that can change the trajectory of this virus. We have had what we call a phased reopening, which is very different than what some other states and some other municipalities have done. Because of that, where we do see some small upward trends in the District of Columbia, is not what we have not anticipated in terms of allowing some small indoor dining or some small outdoor activity that was previously not allowable while we were in a stay-at-home posture, or when we first began our phased reopening. But we have never gone to some of the extremes that other states or other cities did with opening bars or full opening of restaurants. And so because of that, we've had relatively lower rates than other states.
Dr. Nesbitt, I live just outside DC, and I don't think I've been back in the city for the last 3 months. But I do want to ask a question for my friends who are sort of wondering this, who are in this city. What is the current best practice on masks? Should we all be wearing them?
Yes. So what we tell people is that, and we have guidance for masks, and we have some orders for masks in terms of when you're in buildings, when you're in retail locations, that masks should be worn. Our position is, mask, anyone over 2 years of age or older should wear a mask. If people who should not have to be forced to wear a mask, of course, are those people who have a physical disability or where wearing a mask will compromise their ability to breathe. We also adhere to the guidance that has been put out around from the CDC in terms of those who are doing physical exertion. So exercising vigorously and maintaining social distance outdoors. We've made some clarity around that. But as Dr. Ford has observed, we have been noted as a jurisdiction that has great adherence to masks, even compared to some of our surrounding suburban counties.
Now, Dr. Ford, I believe we have a slide that details what seems to be a really striking disparity, racial disparity in hospitalizations for COVID-19 in Atlanta. What's the emerging wisdom, knowledge on why this disparity exists?
Oh, so there are so many factors that contribute to that. When testing first became widely available for COVID, the initial recommendation, actually not even a recommendation, a requirement, was that you had to be referred by a primary care physician to even be allowed to be tested. And so that eliminated folks who were underinsured, uninsured, or simply couldn't even get an appointment. So right there, you set up a disparity before you even started testing folk. That's number one. Number two, we can't really ignore bias as a factor in this, because a lot of folks have been reporting anecdotally that they presented to primary care physicians or EDs and were dismissed and sent home with, you've got the flu, here's some flu treatment or recommendations. And then when they returned, they were, they were so ill that some of them didn't even survive. And so there's a lot of factors. We talk about workforce and who gets to, I always say that sheltering in place is a luxury. Everyone doesn't have the option to shelter in place. And some folks, that's not their life. And so if you have to be one of those people that go out and work every day, you're automatically exposed. And we know that 43%, at least in Georgia, 43% of Black and Latinos do not have the option of sheltering in place. And so those factors all contribute to why we're seeing this disparity. We could talk a little bit about the overabundance of chronic disease, but that's just one piece of the pie. That's too simple to say that that's the cause.
So it's not just I think what I've been hearing a whole lot of is not just underlying conditions, it's a whole constellation of different things.
Right. I mean, that's a kind of a trite way. Oh, well, you have diabetes and hypertension, and so you're going to get COVID. No, there's some other issues around that as it relates to access.
Now, both of you have been involved for a long time in increasing access to care and in reducing the existing barriers to care for people of color, people on the margins in your cities, in your careers for some time. I'm wondering what kind of things are in place right now in DC and in Atlanta that we are able to leverage to reduce some of those barriers that you just mentioned.
One of the things has been a very interesting discussion when the national media and many people started getting very focused on, there's disparities in COVID care and there's disparities in outcomes related to COVID. We're like, there's disparities in health outcomes for essentially every condition. And for a long time, I would tell people, I'm like, there's one that often comes to mind where there isn't, and it tends to be COPD. But you look at everything else, and Blacks and Latinx populations tend to be disproportionately impacted. We have looked at very closely the social and structural determinants of health and how they have to be addressed and how they have to be addressed over time to eliminate inequities and health outcomes. And when we look at those things, when we look at housing, when we look at employment opportunities, when we look at income, when we look at educational attainment, all of those things are really playing into why we see the number of Latinos and Blacks who are getting COVID-19. And then in some communities, you see it also reflected in the death rates. Not in every community, but in some. And so we're seeing that it may have to do with the age of the population. So if your Latino population is younger, you may see your death rates lower in your community. If they are older, you may see it be higher. But when we started to really delve into why this was happening, and Dr. Ford has touched on this, they tend to be more likely to be essential workers or working in critical infrastructure. So their risk of exposure is high. We've also seen that multi-generational households occur. Or they're living in the median or mean average of people in the household is higher than the citywide average, which means when one person gets infected, their ability to isolate and reduce the risk for other people in the household is much lower. So all of those things that we say, we tell people to do, stay in one room, use your own bathroom, they can't do. So when you walk that backward, to your question of, well, what are you all doing? Well, it's the same stuff that we try to do at the baseline: address housing, address the social needs of the individual. So we've had to put things in place that are more on the human and social services side that says, if you are diagnosed with COVID and you have a food access need, we will address it. If you're diagnosed with COVID-19 and you have a housing need, whether it be a long-term housing need or you have a short-term housing need that will help you to isolate to reduce risk of spread to other people in your community, we will address it. So you cannot be myopically focused on this is about expanding access to care only for individuals and increasing testing opportunities only for individuals, but you really have to get to these social and structural determinants of health as well, in the same way that we have been doing that for other health conditions.
I want to pull in a question we have in the Q&A, which relates directly to that response from Ryan from Tampa, Florida. And Ryan asks, are either of your jurisdictions considering declaring racism a public health crisis like some others have, and as a rallying cry to address root causes, which we know are part of the social determinants of health producing these inequities?
Absolutely. Ironically, DeKalb County Board of Commissioners yesterday approved our resolution to declare racism as a public health issue. So I'm very happy. I wanted to piggyback on Dr. Nesbitt's comments about what we were doing in DeKalb specifically to focus. So we have some blessings in public health right now. We are not usually a group that get abundance of funding. And so right now we do. And so if we use that money just for testing and contact tracing, we have done a disservice to this community, because that's not going to get us any more where we need to be. And so if we're smart about this, what we do is do things that prevent this next wave from being as devastating as it currently is, and do some things to change the system. So some of the initiatives that DeKalb County government has supported us in is we are doing much more telehealth, mobile telehealth. We have a mobile farmers market that we had been conducting for years now, but what we're going to do is expand that to not only provide fresh produce to food insecure neighborhoods, but also some clinical services. So when you come to get your cucumbers, let me check your blood pressure. Let's check your sugar. We did think about isolation and quarantine. You know, DeKalb County has one of the largest refugee resettlement communities in the Southeast United States. And so it's nothing to see 12 in a household. And so we have funding to support isolation and quarantine housing for individuals who can't be in their home. And that includes our first responders as well as our citizens. And so we were trying to be really thoughtful about this money. I mean, yes, we have some testing and tracing issues, but we also need to fix this system. And so that, you know, to have this type of funding available to us is a once in a lifetime opportunity to address systemic racism and lack of access and those inequities on a much larger scale, and hopefully have more sustainable awareness of this.
Now, one thing I mean that I've encountered personally is you know, I think obviously the health disparities that exist in terms of COVID-19, the underlying disparities that already existed, they're not just between Black and white Americans, right? You have Latino communities that are in some respects facing a greater burden from COVID-19 in the Black communities. But one thing that I do know that it seems particular to the Black community is a certain element of trust or lack thereof in healthcare systems. Just going on Facebook, talking to my own relatives and trying to get them to wear masks or, think about one day having a vaccine or a treatment. There seems to be a baseline level in some parts of the community where there just hasn't ever been a real interface with the medical community. How do we address that? Have you all seen that? And if you have, how do we address it?
So, what it would be, it would not be wise to try to create a single approach for all communities of color. And we have to make sure that we address them with a culturally appropriate and culturally acceptable services and initiatives. So what we have done is we have created and partnered with community-based organizations that, for example, in the district have very strong expertise that can advise on approaches that are appropriate for Latinx populations, for African American populations, for African American immigrant populations. What it will take to be able to reach those communities are going to be very different. Some of the things that create lack of trust with government are very different when you have immigrant populations that are worried about receiving services from the government because of issues related to immigration, deportation. So we have to be able to address those things, which are different than the African American experience, which is related in historical issues related to research and lack of trust in the medical enterprise. So we have to be able to speak very open and honestly to those issues and address those concerns and get rid of the misinformation that continues to harm our communities and keep them away from receiving the types of medical advances and technologies that can be life-saving and life-preserving. And so I think that those are very real issues, but we will be doing a disservice as public health, as medical professionals, as media, if we blanket approach communities of color and not realizing that these things have to be very tactical. The interventions that we create have to be very tactical and very cultural in nature. And creating those strategic community partnerships are a key way for us to develop the right strategies.
Now, I want to roll in two questions from Juliet and Christine in the chat, because they both have to do with what you just brought up, which was figuring out how to make culturally appropriate ways to disseminate information and get community buy-in. Because at some point in this pandemic, there will be an introduction of vaccines or treatments or other pharmaceutical products. How are we thinking about this proactively and in terms of getting people ready for the next phase, whenever it is, of actual treatment or prophylaxis?
So, communication is the key. And so when you say how we have time to do media, it's really a requirement right now to do media because we have to dispel these rumors. And that's the beauty of longevity. I've been in my position for 15 years. So this is the phase people are used to talking about, talking about these types of things, and I'm bilingual. So I speak to the Spanish community as well, Spanish speaking community. But, that trust factor is critical because there is so much misinformation, even among leadership. And so that creates a lot of confusion. And so, speaking plainly and explaining that this is a novel virus and that we learn as we go along. So what you heard last month may be different right now. And that doesn't mean people are lying to you. It means that we just learned something new. And so really just making yourself available for media so that when questions come up, they're addressed. That's a critical piece right now because the communication is just insane right now. And there's so much conspiracy theorism going on and it's just making a difficult job even more impossible. And, you know, even some of the leadership that is saying, well, it's not that big of a deal and it's a flu. And, you know, we try to explain to them, you know, the medical impacts of this. Just because you survive COVID does not mean you are without long-term effects from it. And so just even trying to educate our leaders on some of this is a constant challenge. And so communication is the key.
I want to follow up with you on that point about the long-term complications. That's one thing I think a lot of folks haven't really talked about. You're in the middle of the storm now. Are you seeing the beginnings of that kind of burden being added?
Absolutely. I mean, I have a dear personal friend who is probably one of the few people who can actually say she survived a 5 weeks on a ventilator. Well, yeah, I mean, that's actually the record that I've heard, but she's home, but she has, you know, she has to have speech therapy, occupational therapy. There were a lot of unexpected neurological impacts from this. And so just to say you survived COVID is not, that's why we say this is not the flu. When you feel bad for a few days and then you're back at work with the flu, this virus has a lot of long-term impacts that we're just now figuring out, a lot of cardiac sequelae from it, a lot of lung issues. And so just to not be, you know, on a ventilator is not where we want to be.
And we only have a few minutes left. I want to ask both of you, what's the deal with testing? Where are we right now with testing? I know, Dr. Ford, I know there was a big story about Mayor Bottoms and having something like 7 or 8 days between test and result. What's the deal with tests generally? And are we seeing any of the, you know, expected disparities in access to care also playing back in terms of who can get a test and who can get a good result?
We have open testing right now in DeKalb, and so that getting a test is not the issue. The problem is the lab. And so actually I had to explain this yesterday. The Board of Health does not run the tests. And so once it leaves your nose, it goes to a lab. And so Mayor Bottoms is in Metro Atlanta in Fulton County, where, you know, their turnaround time is, you know, 5 to 7 days because they use a different lab. DeKalb's turnaround time is between 24 to 72 hours. So it is so geography specific, and that's really frustrating because it literally depends where you go to get your test, how quickly your results return.
Yeah, and I would say, you know, it's one of the things too that we really want people to understand is that when we've talked about how complicated testing has been in this country, back in March and April, when we were talking about testing, we were talking about not having enough swabs, not having enough reagents to even do the test. So when we were desiring to create locations and places for people to do tests, that we even had those challenges. Right now in the District of Columbia, on any given day, the city itself sponsors, has its own staff, has sponsors Monday through Friday at a minimum 6 to 8 locations across the city for people to go and get tested without an appointment. And on Saturday, 4 to 6 locations. So that's not an issue. That's not a barrier. And then we have our hospitals, the private sector, all these places have testing. It's when you go and get tested and that test goes to a lab that the more people who show up every day without an appointment. Back in early June, there were 1,500 people a week. Now there's 8,000 people a week who are showing up to get a test. And that the number of staff working in those labs, the number of instruments and robots running those tests has not increased substantially. So you're going from previously being able to get a test result in 24 to 72 hours to now it being 5 to 7 days. Now, where you get your test result definitely within hours is still, if you're someone who is sick enough to be in the hospital, people are still getting those results very quickly. But a lot of folks who are, stepping outside of their homes, walking over to a firehouse in the nation's capital, which is a huge convenience for many people who want to know their COVID-19 status, that period of time, the more people who walk out of their house every day to get a test without an appointment, the more stress it puts on laboratories.
I want to wrap up very quickly by condensing a question from Celeste from DC, which is asking both of you in like 30 seconds. What has this pandemic revealed or shed light on the state of public health in your cities and in this country?
For Metro, it's taught us that we need to figure out a different way to deliver care, that we need to start expanding our horizons more into the technology field and utilizing our telehealth capacity much more than we've been using it. It has taught us that a lot of our own functions can be done remotely, and we need to be thinking more about that. That we need to continue to be mindful of disparities, that we need to prevent this next wave from being quite so devastating, and we need to always be pulling that data and making sure that it's accurate.
You know, I would say here for us, we've known that inequities existed. We have a health equity report that talks about it. What it's been able to do for us is to get more buy-in from more entities and more sectors to work very intentionally with us to help eliminate those equities, especially in those 8 other sectors that have a responsibility for it. And as we reopen under Mayor Bowser's vision, we operate under a HOPE rubric. So health, opportunity, prosperity, and equity. And so everything that we're doing in our phased reopening as a result of COVID is done intentionally with bringing more hope to the District of Columbia. So I would say that it definitely is linked to the public health infrastructure, but also helps us not get back to normal, but to get back to a better place.
All right. Well, thank you both for taking time out of busy days to join us today. And thank you everybody who asked questions and stopped by for this. This was great.
Thanks so much.
Thank you, Vann. Thank you, Dr. Nesbitt and Dr. Ford. And thanks to all of you for watching. We are going to take another quick break, and we will see you all at 1:30 p.m. Eastern for a continuation of our Pulse Summit, which kicks off with an interview with Dr. Anthony Fauci and the Atlantic's Ed Young. So see you then.